So it's my privilege to be invited to the West Coast to give a talk on evidence-based transfusion practice. Thank you for having me. Thank you for, I get to visit anesthesia all morning and now lab medicine in the afternoon. So it's 2 for 1. And it's been such a great visit. So this is our topic today, and this is where I practice. This is our new hospital that opened 5 years ago. The left side was paid for by Sheikh Zayed from United Arab Emirates. The right side by Michael Bloomberg from New York City. So the Jewish and Arab philanthropists came together to give us a new hospital and hyphenated their names. It's called the Zayed Bloomberg New Clinical Tower. Every good talk needs to begin with a disclosure slide, of course. And here's mine. I've consulted for 3 companies. But more importantly, a potential bias in my talk is I personally had a life-saving transfusion in 1988. And we'll start with that story about how blood saves lives. So I was a third-year resident at Johns Hopkins in anesthesia. It was a bicycle versus car head-on collision. I was on the bike. Helicopter to shock trauma, which is where John Hess was employed. And if it weren't for a blood transfusion, I wouldn't be here today because leaving the hospital with a hemoglobin of 7, I calculate that I lost an entire blood volume, or probably about 10 units, from a ruptured spleen. So there's no doubt that blood saves lives. In fact, we can see signs like this in our hospital. Elevators give blood, save a life. And for many years, we thought that perhaps more blood was better. Why not? It carries oxygen. How can it be bad for you if it carries oxygen? Well, then how come over the last decade, why is blood use down by about 30% across the United States? We've gone from about 16 million units a year of red cells to about 11.5. So blood use is down about 30%. And why is this? We're going to look at this question. In fact, this is in the news recently in the New York Times. The blood industry is shrinking. As we use less blood, what kind of industry can sustain itself with a 30% decline in the product that you're selling? So we're going to see why this is happening. In fact, part of the story begins in 2012 when the Joint Commission held their Overuse Summit. And they determined not only that blood transfusion was the most commonly performed procedure in U.S. hospitals, but also one of the top 5 overused procedures. In fact, right up there with antibiotics for the common cold and heart vessel stents as an overused procedure. And this is based on evidence that we'll see in a minute. And then along came the Choosing Wisely campaign. Who's heard of Choosing Wisely? So this is a national campaign started in 2013, pretty recent, to reduce unnecessary tests and procedures. And now we have 6 societies in the U.S. With aims to reduce unnecessary transfusions, including the anesthesiologist, the intensivist, the hospitalist, the hematologist, OBGYNs, and even the blood bankers have Choosing Wisely aims. So we're going to look at this. And one of the best things about patient blood management is you can achieve all 3 of these at the same time. You can reduce risk, you can save cost, and improve outcomes. And we're going to look at all 3 of these in the next few slides. We'll start with risk. So I like to divide the risk of transfusion nowadays into 3 categories. The rare events, the not so rare, and then the common events related to transfusion. So luckily nowadays, for example, hepatitis C and HIV, with the testing that we do, is considered rare. About 1 in 2 million transfusions maybe even better than that now. So that means about 5 or 6 people in the US will still get HIV from a blood transfusion if this is true this year. So the risk is not 0. But TRALI, transfusion-related acute lung injury, is thought to be much more common than viral risk, and is also 10% fatal. So it happens to be the #1 cause of transfusion-related death, is TRALI. Also hemolytic reactions, most often from a wrong unit, which is a higher risk than we would like. That can be fatal. And then TACO, transfusion-associated circulatory overload, is the #2 cause of transfusion-related death. Much more common than all these other events. The problem is that we're so focused on hepatitis C and HIV for so long that now the risk of these viral transmissions from a transfusion is so low that it's been seriously compared to the risk of getting struck and killed by lightning. Jeff Carson looked at lightning strikes all around the 50 United States, and he found the state with the highest risk of lightning strikes was about 1 in 2 million chances so it's similar to the risk of HIV from a transfusion. So people take the wrong message home now that, oh, the blood is so safe, we can just give it to everybody, forgetting about TACO and TRALI, which are much more common. What about cost? So in our health system, that's 5 hospitals. This is what we spend each year for blood acquisition cost. So it's about $28 million a year. That's $1 million a month or more for red cells, $1 million a month for platelets. That's a lot of money. And only $1 million a year for plasma and cryoprecipitate. So you can see if we reduce the blood spend by 10%, we can save almost $3 million. And what you should know is the way we're paid now for blood and for patient care in general is by bundled DRG payments. So people ask me all the time, aren't we paid for blood? And the answer is basically no. It comes straight out of the hospital's bottom line. And the other thing to know about reimbursement is the true cost of a transfusion is about 4 times higher than what we show here. So to bring the blood all the way from the donor to the recipient, there's 70 steps in between. And if you put a price tag on the whole process, it's about 4 times higher than this. So a unit of red cells goes from $200 to $800. Here we have what I call 9 landmark randomized trials, all supporting hemoglobin triggers of either 7 or 8. And these are pretty much all within the last decade. So these are relatively recent except for the TRIC trial. And here's the hemoglobin triggers on the left that these studies support. You can see even in critically ill ICU patients, the hemoglobin trigger recommended is 7. In cardiac surgery patients at the bottom, 7.5 or 8. And when these studies compared to higher hemoglobin triggers shown on the right of 9 or 10, 5 of the studies showed the same outcome, meaning no benefit to giving extra blood. And 4 of the studies showed a worse outcome, meaning actual harm to giving extra blood. And the biggest study to date was the one at the bottom, the TRIX-3 trial in cardiac surgery by David Mazer, was twice as big or more than any other study, 5,000 patients. And he found in particular that the patients who did worse when you give them extra blood were the older patients, age 75 or greater. So for years we thought older patients need more blood because they're older and sicker. And now we see that they may actually do worse when you give them more blood than is needed. So my area of interest is collection and analysis of data from electronic records. And I was asked to give a presentation to the Red Cross on data collection in 2012. And after my talk, this is what we concluded. I know this sounds funny, but we concluded that medicine lags behind fast food restaurants and auto parts stores in data collection. So it's actually true, because back then about half of US hospitals were still using paper records in anesthesia, for example. So this is the paper record that we were using up until 2009. And this is where we charted blood. So it's virtually impossible to collect data from paper records. If you've ever tried it, you would know what I mean. And then in 2010, we switched to the electronic records. And every unit of blood component was entered into the database, as were the lab values that we send from the operating room. And so we queried the database. And what we did, this is one of my first papers in the blood field back in 2012. We ranked all the surgeons at Johns Hopkins Hospital on the left and all the anesthesiologists on the right according to their average hemoglobin threshold for transfusion. So you can see this, the left edge of the red bar is the hemoglobin before the transfusion, and the right edge of the red bar is the hemoglobin after the transfusion, or at the end of the surgical case. So we call that the trigger and the target. And we had found this wide variation in practice, about a 3-gram variation. And so our paper was written up in the media about this wide variation in transfusion practice during surgery and the need for improved blood management, and how blood transfusion is the most common procedure performed in US hospitals. And note that the write-up was in the business section of the newspaper, because they also noted a huge cost savings opportunity if we could reduce variation in practice. So we took the hemoglobin graph and then we put names on the y-axis, and then people paid more attention. We also superimposed the shaded range up the middle, which according to the 2 largest randomized trials is where the hemoglobin values should be. So you can see, this is about 9 years ago, we had a lot of over-transfusion going on to the right side of the shaded range. So then we took the data graphs and put them on the door with names. And when you put doctors' names on a bar graph on a bathroom door, they will line up to see where they compare to their peers. And that's what they did. By the way, this is the anesthesia office bathroom, not truly public. But everybody wanted to know where they were on the hemoglobin curve compared to their peers. And at this point, I tell a story about my favorite surgeon. We'll call him surgeon number 44, because he was at the very bottom of the hemoglobin curve. And he's one of our most senior, famous surgeons. He now just finished his 3,000th Whipple surgery for pancreatic cancer and retired. He did his last Whipple at age 81. And so I sent him this graph on Christmas Day, 2011. And I said, hey, you have the highest hemoglobin in the whole hospital in your transfused patients. And this is what he told my colleague in his next Whipple. He said, if you hang that blood, Steve Frank is going to be all over our case. And so he either heard about the data on the door, or he didn't like being on the edge of the curve. And no one knew he was on the edge of the curve until we got the data from the electronic records and actually looked at it. This is his transfusion rate after we showed him the data. His red cells dropped by over 50%. Surprisingly, his plasma and platelet transfusion utilization decreased as well, because a lot of surgeons and anesthesiologists now believe in this 1-to-1-to-1 ratio, right? Which is supposed to be for massive transfusion, not for mild or moderate transfusion. But nonetheless, we saw a decrease in all of the blood components. So that's the power of electronic record data, if you can harness it and use it for feedback to improve practice. The other use of electronic record data that we've shown is to improve the process of pre-op blood ordering. That is, type and screen, type and cross, or no blood order at all. So we had a very old surgical blood order schedule, Johns Hopkins, from the late 1980s, and we decided to update it with real data from the electronic records. So we remade our surgical blood order schedule, or the MSBOS, as we call it. And this is what it looked like. We had 135 kinds of surgery and the recommended blood order. I blow up urology here as an example. And you can see robotic radical retropubic prostatectomy. We had one case out of 1,000 that was transfused for robotic prostatectomy. And so we decided they did not even need a type and screen. We call it no sample. So you don't even have to send a type and screen. We got the urologist to agree. And guess what? If you have that 1 in 1,000 case where they get into the iliac vein, remember in med school they taught you that O negative was a universal donor? Well, that's still true. I have to remind my colleagues all the time that it's virtually impossible to kill someone with O negative blood. In fact, we even use O positive blood for everybody who's not a young female. And so we have a list of cases that are rarely or never transfused. You can see like a thyroidectomy, for example, is about 1 in 1,000 transfusions, cases that are transfused. So we improved the process and we saved money and time and effort this way. So blood management has been called giving the right dose of the right product to the right patient at the right time for the right reason. If you dig in deeper, though, for example, pre-op anemia treatment, if you can give $5 worth of iron pills and avoid $500 worth of blood, say for a menorrhagia patient for hysterectomy, that makes a lot of sense. Sometimes we even get more aggressive with pre-op anemia treatment with intravenous iron or even erythropoietin when it's indicated. Less invasive surgery. So I told you that robotic surgery patients for prostates or hysterectomies are now rarely or never transfused. In fact, that's the major difference we see with robotic and laparoscopic surgery, that they really don't go home or back to work earlier, especially after prostate surgery, but they do get a lot less blood. Endovascular surgery for aortic aneurysms has dramatically reduced blood loss. This is part of the reason for the 30% decline in transfusions across the US, is surgery has evolved to be less invasive. The cell saver, or blood salvage, has been called the centerpiece of blood conservation. We're going to talk about that in a minute. Topical hemostatics, newer cautery devices. I'm going to show you how much blood your patients lose in the ICU each day to phlebotomy. For lab tests, we'll talk about decision support, or what I call the annoying pop-up alerts. We'll talk about that. Tranexamic acid, rapid turnaround, point-of-care testing like TEG, audits with feedback, and education like we're doing right now. So I'm a cyclist, and one of my heroes is Lance Armstrong. And his drug of choice was erythropoietin. And regarding pre-op anemia treatment, when this drug came out, it was like magic. Everybody wanted to give it. Now we're cautioned with the black box warning from the FDA about thrombotic events and promoting tumor growth. So we only use it in special circumstances. We give a lot more intravenous iron, actually, than we do erythropoietin. The cell saver. A lot of people that don't work in the operating room don't even know what it looks like. So I include a picture here of a cell saver. There's 4 manufacturers of cell savers now. And it basically collects the blood the patients lose during surgery, centrifuges it with a saline wash to wash out any debris. It also washes out the plasma and the platelets, So what you're giving back to the patient is just red cells and saline. So there is a limitation that the plasma and the clotting factors and the platelets are washed out, but you can save a lot of red cells. In fact, these red cells we think are higher quality than those coming from the blood bank, because we did a comparison of 2,3-DPG levels, for example, and the cell saver blood is shown in green, and it had normal 2,3-DPG levels compared to fresh blood in the navy blue. But the banked blood or the stored blood was about 90% depleted in 2,3-DPG. And this occurs after about 2 weeks of storage. The 2,3-DPG levels are down and the curve is left shifted. There's the P50, for example, and here's the hemoglobin oxygen curve that we measured, showing a left shift with the stored banked blood, but no shift at all for the cell saver blood compared to fresh blood. So this paper was written up in the media about recycled blood or cell saver blood being higher quality than donated blood. And they said we recycle a lot of things: paper, plastic, metal, and blood. So the cell saver has been around since about the late 70s. And who wouldn't rather have back their own blood compared to someone else's coming from the blood bank? So phlebotomy blood loss in the ICUs. We took a survey in the 5 adult ICUs at my institution about how much blood is removed from the patient for lab testing. And the average ICU pulled about 60 mLs of blood from the patient, either to send to the lab or thrown in the trash to clear the lines, to clear the saline out of the lines. So that's just over 1% of your blood volume if you're a normal size adult. If you're a small adult, that could be 2% of your blood volume. So that's 1% is how much erythropoiesis you have every day. So you're basically canceling out erythropoiesis by sending that much blood to the lab. And in the neurocritical care unit, where they use this simple device to return the wasted discard, they were able to cut blood loss in half. Colleen Cook, who's my department chair, when she was at the Cleveland Clinic, she had this paper with a provocative title, Contemporary Bloodletting in Cardiac Surgery. She said she was astonished by the amount of bloodletting that occurs in the ICUs from phlebotomy. And she said that some patients lost 1 to 2 units of red cells due to lab testing. And those were patients that were in the ICU for more than a week. So it does accumulate and build up. We've switched to smaller phlebotomy tubes across the whole hospital. Now we're using the medium-sized tubes shown in the middle, pediatric. They hold between 2 and 4 mLs, basically. The adult tubes hold between 5 and 10 mLs. And in special cases, we use neonatal tubes that only hold 0.5 mLs. So we use those for true neonates and some Jehovah's Witness patients. The lab doesn't much like them because they don't run through the machines and there's not enough sample for add-on tests. And they also don't have a rubber stopper on top, so you have to open the cap to fill them. And they say there's a risk of splash injury. So we use them for special cases. We mentioned annoying pop-up alerts. Do you guys have those in your electronic records? We do too, and I don't like them. But I designed this one. And actually, I designed and got this best practice advisory approved in William Osler's office. That's the office where we met to design this order set. So we computerized medicine in his office. He wrote the first textbook of medicine in the US. So this is one that says if your patient has a hemoglobin of 7 or greater within the last 24 hours, it says, oh, they may not need a transfusion. And we even reference the 2 biggest randomized trials in the New England Journal. So if you click these hyperlinks, you can read the full manuscript of the randomized trial, so they know this is just not my opinion. And then if you want to proceed with the order, you have to pick a reason. For example, active bleeding is the #1 reason that people choose. The second most common reason is symptomatic anemia, which is tachycardia, hypotension, or dyspnea. So you can proceed with one more mouse click. And we've shown that education plus these decision support alerts works, especially in combination. We went from 1,000 units a month of red cells with hemoglobins above 8 to about 400 units a month. So that's a 54% reduction in these out-of-guideline transfusions. At the same time, for surgical blood use, we had a 14% decrease across the board in surgical blood use. So tranexamic acid, which is an antifibrinolytic, is being called a game changer now at the national orthopedic meetings. So it's been around for about 50 years, but only in the last decade is it being used to reduce bleeding and transfusions, especially in orthopedic surgery, in cardiac surgery, in trauma, and also in postpartum hemorrhage. So when we started using tranexamic acid in joint replacements back in 2012, we saw this dramatic decrease in blood utilization. We also hired 4 new surgeons that year, and the FOCUS trial came out in the New England Journal supporting lower hemoglobin thresholds. So as usual in clinical medicine, we have more than one thing changing at a given time. But tranexamic acid is a hot topic. In fact, in 2 of the largest randomized trials ever, 20,000 patients each, tranexamic acid in trauma patients in the CRASH-2 study reduced mortality between 9 and 15%. And in postpartum hemorrhage, just 2 years ago, it was shown to reduce mortality between 19 and 31%. So especially if you give it early, if you don't give tranexamic acid in the first 3 hours, it had no benefit for mortality. So I should add that in none of these randomized trials did TXA cause an increase in thrombotic events. So it seems like the new wonder drug. It's only $36 a gram. So if you can save a life from postpartum hemorrhage for $36, it seems like a pretty good deal. Blood management programs are very data intensive. So we designed these data dashboards when we switched to Epic about 3 years ago. We had our clinical analytics team. They don't like the word IT. It's too generic. But the clinical analytics team, using a ClickView business intelligence platform, built these dashboards for us. And from these dashboards, we generate monthly reports that we send out to all the departments across the institution. And this is what the monthly reports look like. I use orthopedics here as an example. So the orthopedic surgery attendings are on the y-axis. The number of red cells ordered are on the x-axis. And this doesn't account for the number of cases or anything. But what's important is the green, yellow, red. So green is those transfusions with the preceding hemoglobin less than 7. Yellow is 7 to 8, and red is above 8. So you can see, for example, one orthopedic surgeon had 80% red, and about the 6th one down had 0 in the red zone. So it sets up a competition to do better among their peers. And we since switched to put names on the y-axis. The chief of surgery said, look, people pay more attention if you put the names right on the y-axis. And I have to remind them, this is not morbidity, mortality. This is just a hemoglobin trigger, okay? So putting names on the data seems to work pretty well. People are still offended by red, I will tell you. One thing we noticed early on, we have 5 hospitals in our health system shown here, that at 3 of the hospitals, a large number of red cell transfusions were ordered as double unit transfusions. At 2 other hospitals, a much smaller number were ordered as double units. And so we started in 2015 a campaign called Why Give 2 When 1 Will Do. And I've heard that you had a similar campaign. And at first I didn't like it because I thought it was too cute, like a slogan, and I didn't think it would work. Why Give 2 When 1 Will Do. But it actually had more impact than any other intervention. I call it the lowest hanging fruit in a blood management program. If you went to med school when I did back in the 80s or 90s, you were taught the dose of blood was 2 units, no questions asked. It wasn't until Choosing Wisely came out in 2014 from the AABB that the experts in the field started to advocate for single unit transfusions and then reassess the patient. So we took the Choosing Wisely message, and I designed this in PowerPoint. I pasted and cut things and moved them around, and we came up with this screensaver message, Why Give 2 When 1 Will Do. And we had this launched across the hospital on screensavers so patients would see it, their family members would see it, nurses, nurse practitioners, physician's assistants, interns, residents, fellows, attendings. That's about 9 different kinds of people that would see this, even if they didn't go to grand rounds or if they slept through grand rounds. They would see this, and then they'd see about 10 hand washing awards come up for all the hand washing players, and then they would see this come back. And now we have a lot of other quality messages on screensavers. We have antibiotic stewardship, we have DVT prevention. So people have taken to the screensaver messages for quality improvement. And we saw the double unit transfusions shown on the right went from about 70% to about, we're now down to 20% double unit transfusions. And at the same time, we share this logo on the left with hospitals that want to use it. And if they want to do a Why Give 2 campaign, I heard that you guys had screensavers with the message. You're the 2nd hospital in the country that I know of that have used screensavers for this purpose. So we had pretty good success with red cells, so we moved on to platelets. And now on the monthly reports, we include a platelet component. And we have thresholds for platelet counts before platelet transfusions of 50 and 75 and 100,000 platelets. So for example, in surgery, they hardly ever give platelets above 100,000. And the top 4 people are doing liver transplants. In cardiac surgery, though, a lot of people give platelets above 100,000, but they're often on Plavix or aspirin, right, for cardiac surgery. So we started to advocate more platelet function testing with thromboelastography. And this has been around for a long time, TEG, but recently we started using it in trauma, in postpartum hemorrhage, in cardiac, of course, and in transplant, like liver transplants. And you can avoid overuse of platelets with thromboelastography. In fact, when EPIC was launched 3 years ago, we noticed that people were ordering a double dose of apheresis platelets, or a 12-pack of platelets instead of a 6-pack. And EPIC made it really easy to order a 12-pack. That's $1,000 worth of platelets, because it said, do you want 1 dose or 2 dose? And people didn't know what a dose or a unit of platelets was. So we actually removed the choice for 2 doses of platelets from the Epic. It came out of the box with a 1 or a 2. And so we removed the 2, and we're on pace to save about $1 million or a 10% decrease in platelets this year compared to last year. So Epic almost hurt us in that way. In fact, I like to say that platelets are the highest risk and cost of all the 3 major blood components. You guys know that the major risk is bacterial sepsis. We were averaging about 1 septic platelet transfusion a year at Johns Hopkins. In 2016, we had 4 documented septic platelet transfusions with 1 death. So the next year, we started a secondary culture of platelets. So all of our platelets that come from the Red Cross, that's where we get them, are now secondary cultured. And by the way, this risk is about 150 times higher than HIV or hepatitis C. And so we're trying to really improve utilization of platelets. About a year ago, we published our results of our health system-wide blood management program. And this is the decrease that we saw for red cells, plasma, and platelets over a 4-year period. And the associated cost savings over the 4th year of this period was about 10% decrease in our annual blood spend, which was our goal of $2.8 million annual decrease. So the health system uses us as an example for quality improvement and cost savings. And we were featured in the Year in Review as one of the top 6 accomplishments at Johns Hopkins. They talked about the blood and the money that we're saving and how we used the Epic electronic health record to get data to improve practice. So everybody hates Epic when it comes out, but if you can show that you can get data and use it to improve practice, then people, they jump on board. Now, what about outcomes? It's fine and well to give less blood, but how do the patients do? And just last year, we decided to look at outcomes. So we chose orthopedic surgery, all the orthopedic patients over 4 years, and we reduced their hemoglobin trigger and target by about 1 gram, shown on the top. Pre-blood management in red, post-blood management in blue. And we reduced blood utilization by 32% in orthopedics. But what about outcomes? So we looked at length of stay, 30-day readmission rate, and morbidity and mortality. And we found that all the outcomes improved, except mortality was unchanged. It was only about 2 in 1,000. So length of stay went down 33%, 30-day readmission by about 30%, morbidity or mortality about in half. So we think patients do as well or better if you give blood appropriately. The last thing I'll cover is what I call outcomes at the extremes of transfusion. So how do patients do when they don't accept blood? We call those bloodless patients. They get what I call extreme blood management. And how do they do after massive transfusion? After the 5th or 10th cooler of blood, how do they do? So we have a program or a center called Bloodless Medicine and Surgery for patients who won't accept transfusion. And we've had it for about 6 years now. We've even written papers like this one, the top 10 things to consider when patients won't accept transfusion. And the first real paper we had was looking at outcomes in our bloodless patients compared to a matched group of controls. We looked at ischemic events, respiratory, renal, thrombotic events, and then infections. And we found that if you give them the full-blown treatment to avoid transfusion, they did as well or maybe even better. There's a hint towards less infections in the patients who declined transfusion. And how do patients do after massive transfusion? So we took every single patient admitted to Johns Hopkins over 6 years, and we plotted them according to their blood dose on the x-axis in 10-unit increments. And we looked at mortality on the y-axis, and we knew that patients getting more blood were more likely to die. That's obvious because they're sicker patients having bigger surgeries. But we didn't know the slope or shape of this curve. So it turns out the shape is linear and the slope is 1, meaning for every 10 units of red cells, we saw a 10% increase in mortality. And at 50 units of red cells, we found 50% mortality. So it's kind of like flipping a coin when you get to 50 units as to whether your patient is going to leave the hospital alive. And we think that's pretty good odds, by the way, compared to, say, pancreatic cancer. But more importantly, what types of morbidity did they suffer? And it turns out the patients getting massively transfused are at greatest risk for infections and thromboses. So we should be more vigilant to prevent, treat, and diagnose infections and thromboses because they're almost 5 times more common than renal, respiratory, or ischemic events. I just want to wrap up by saying that blood saves lives when you need it, but only increases risk and cost when you don't. And here's surgeon number 44. The 6 P's to stop surgical bleeding: pressure, patience, prayer, proline, plasma, and platelets. Hopefully in that order. And I want to thank all the people on the blood management team because it's definitely a team sport, as is any quality improvement effort. Thank you.
Questions for Steve?
Time for questions. Yeah.
Yes. Yeah. Hamilton.
Hi, Hamilton Sang. We met earlier. I had a question. We don't have a Ms. Boss here. How do you get one instituted in a place where how do you get one instituted in an institution or convince people to all agree to something? What's your approach?
Sure. So we had one that was almost 30 years old and needed updating. So you want the easiest way or the best way? The easiest way is to adopt someone else's and modify it if needed. So for example, in our paper that we did on this, the appendix is the actual surgical blood order schedule. So some places have taken our appendix and just used it or modified it based on, well, maybe we don't do as much of this, or we do a lot of this and we do it better, or you can modify it if you want, if your surgeons don't buy into it. But you should run it by the surgeons and the anesthesia team to see. You don't want to run it by too many people because to get agreement is going to be difficult. But especially the surgeons should probably buy into it. Otherwise, you're going to have to look at your own data and perhaps use our formula that we published in the paper with estimated blood loss, percent transfused, and units per case. And then in the formula, we use that to make the algorithm. Yes, Monica.
Hello, Steve. That was a very nice talk. Thank you. I have 2 questions for you. The number one is, you very nice describe a history of success, but I'm guessing that this actually summarizes a lot of work and also struggles. So I wanted to know which were your most common struggles and how you navigate those. In particular, for instance, change in culture, because nobody accepts change rapidly. And the second question that I have is, I understand that you're an anesthesiologist and this is mainly in the OR, but have you extended these efforts in other areas of the hospital? For instance, ICU or hematology, oncology, and in general other areas?
Sure. So what were the biggest challenges, and have we taken this outside the OR? Biggest challenges are up front at the beginning, and I think to convince the hospital administration to fund the program, because I like to say that you can't do this on nights and weekends. You need non-clinical time so you can do the work. And for example, we have monthly meetings, and I make the agenda and I make slides for every meeting. So I spend a few hours doing that. We generate these reports that go out every month. That takes time. So if you don't have funded non-clinical time, we have 5 people that have either partial or one of them is actually 100% funded to do this. But we've also shown a 400% return on investment. So for every dollar that we spend on the blood management program, we save $4 in return. So that's how we justified this in the business plan that we created. So that's number one, and that was the biggest challenge. Once you get the funding, then you can get the people in place to do the work. Number two, we started with perioperative or intraoperative transfusion because that's where I work, and those are the people I know. But now we send reports to 14 different departments, including Department of Medicine, including the medical ICU and the CCU, cardiac care unit. So we actually send reports to medicine and surgery and the ED, emergency department, and oncology. Now, oncology has their own set of rules, though, so that they can either look at our reports or not look at them as they like. But at least they know that if they know that you're watching, they will do better.
Thank you.
Steve,
Yes, John.
You're using thromboelastography as part of your attempt to save blood. You know, the test is notoriously insensitive. What do you think it's actually doing in terms of, shaping behavior?
Sure. Well, first of all, you're right. Ours doesn't really measure aspirin or Plavix.
Yes.
Okay, we admit that. So it can only be so useful, for example, in cardiac surgery. However, if I have a spine surgeon who's doing a lumbar fusion, and I've given 2 units of red cells, and they're telling me to give plasma because the patient's bleeding, all I do is I send a tag for $28, and I tell them, oh, the tag is normal. And a lot of the orthopedic spine surgeons don't even know what a tag is. Well, maybe they do now. But at least we have a reason not to give the plasma after 2 units of red cells. The same is true with platelets. So I like to say there's a triad. Okay, we use the tag, the lab value, and the clinical picture. So if we're doing a liver transplant, for example, I don't just use the tag or just use the platelet count. I also look at the clinical picture. If 2 out of the 3 says we need platelets, then we'll give platelets. So it's really, there's still clinical judgment involved, of course.
So as long as John brought this up, I guess what does TEG add that you can't get from just getting a prothrombin time and a platelet count and a fibrinogen, for example?
Sure. So what I've seen is about 50,000 platelets is where the TEG starts to become abnormal, okay? So some patients that live with 40,000 platelets, they'll have a borderline TEG, but they won't be bleeding. And so it's really a triad. I think you need all 3, the clinical picture, the platelet count, and the TEG. Because some patients will have an abnormal TEG at 50,000 platelets, and some won't. I think maybe their platelets don't work as well. It's not just number, but it's function as well. Let's say they're uremic, they have hepatorenal syndrome. Maybe their platelets don't work because of that. That's the easiest answer I can give.
So I liked your example of changing the default options in Epic and just saying you can only have one unit at a time, one dose at a time. And we've certainly had similar experiences at the EHR, and I'm sure you have other examples. Does your institution have an ongoing relationship with Epic such that they will change their foundation build on the basis of some of those kinds of decisions that you made so that we can benefit from them when we put in the standard build of Epic?
So yes, there's certain key people in your institution that they actually work for Johns Hopkins Hospital, but they're on the Epic team. And so if you tell them, they have like a queue of problems to solve. If you tell them that it's a patient safety issue or a huge cost savings opportunity, or, I mean, if you're giving a 12-pack of platelets because an intern doesn't know whether they want 1 dose or 2 doses of platelets, and that's a high priority issue. So we know if you're connected to the Epic people that can get things done, and you learn who they are pretty quick, then we push that through within like 72 hours. Because
my question was more whether your Epic analysts take that back to the mothership and they recognize that the faults that they provided you were not good ones and adjust their foundation. Have you had the experience of having that back and forth with the vendor and providing?
I don't think it made it to Verona, Wisconsin. I think that you take a bunch of your people on the ground in the building and you put them on the Epic team. And they solve the problems right here and now. Whether it goes back to Wisconsin, I'm not sure. Because the problem with Epic is they don't sell you these packages with the order sets already built. You got to build them yourself. And it takes meeting after meeting after meeting to build the order sets with the indications. And if you want best practice advisories with logic, then you got to build those and you got to test them. And by the way, you got to do them for pediatrics and you got to do them for adults and you got to do a blood order set for neonates. And you got to do red cells, plasma, platelets, cryo. And there's a prepare order and a transfuse order. So guess what? That's 24 blood order sets if you multiply. It gets complicated.
Again, thank you for such a wonderful and hopeful talk.
My pleasure.
Yes, especially when you talk about Epic in a positive way. That's remarkable, actually.
Yeah.
But my question is whether you've also addressed other groups besides the surgeons and anesthesiologists. You mentioned other departments, but what about reaching residents and also transfusion nurse specialists? Do they play a role in this blood management, and how have you trained them?
Sure thing. So, interesting question. We realize we have provider type in the Epic data. So 33% of the blood in our hospital is ordered by nurse practitioners and physician's assistants. We didn't even know that until we looked at it. So we recently included them in our education process. So I give a talk to that group of advanced practice providers because they order 33% of our blood. Residents order 60% of our blood. The other 7% is ordered 5% by fellows and 2% by attendings. 2% know how to order blood or actually order blood. So your point you raised is a good one. If we're just feeding back the reports to the attendings, is it really getting to the people who are ordering the transfusions? And so we've been generating reports 2 ways, by the attending physician for attribution and by the ordering provider. So the Department of Surgery wanted to know it by ordering provider so they could feed back to the residents. And so we've done it both ways. It turns out the residents, there's a whole bunch of residents that may all order 2 units of blood per month, okay? But if you attribute to attendings, there's less of them and there's more blood. So you're kind of diluting the reports by having more people giving less blood.
And the transfusion nurse specialist, do they play a role? Do you have such?
I think we have those in oncology, and as far as I can tell, they kind of follow their own rules. I gave this talk to the oncology attendings, and the response was, "We don't order blood, our nurses do that." I think that's what you're talking about. Yeah.
A quick
Renata.
question.
You have an RN in your group, right? You have a transfusion safety officer, transfusion safety person within your group. That 100% person that you talk about that's funded, you have somebody like that in your group. Is that
So we do, and so that person helped us develop and educate on the MSBOS, for example. We recently revised the MSBOS, and she helped with that and to get it out where it needed to be. She also helped with the monthly reports that we send out, and she helped with the recent Joint Commission certification that we got for patient blood management. It's a new offering from the Joint Commission. John knows all about it because we designed the standards that they use. And so it started 2 years ago, and now you can get Joint Commission certified in patient blood management. There's about 10 hospitals now in the country that have done it. So she helped with that as well.
Since you embarked on this journey, what are some of the major oppositions and criticisms you've attracted?
Okay. So the trauma surgeons didn't like the why give two when one will do. That was one pushback, okay? They said it might be dangerous. And we said, of course, we need to use clinical judgment. The sickle cell doctors didn't like why give two when one will do, because they often do like a complete exchange transfusion. But those are special cases. Attribution is the trickiest part of the whole deal. So it turns out attribution of the transfusion is tricky because in the orthopedic patients, about a third of the blood is given by anesthesia. About a third of the blood is given by the critical care docs in the ICU. And only a third of the blood is ordered by the orthopedic service. So what they do is they say, I didn't give that blood, and they argue about the attribution. And so that's the tricky part of the job. And we just admit, yeah, it's hard to do attribution. And that's why sometimes we do attribution by who ordered the blood rather than the attending physician.
Well, thank you, Steve.
My pleasure. Yeah, thanks, John.